I'm Eric Jelovsek. On behalf of the NICHD Pelvic Floor Disorders Network, thank you for allowing us to present our study. Our disclosures are listed. In women with mixed urinary incontinence, clinical guidelines recommend treating urgency incontinence prior to consideration of surgery for stress incontinence, because surgery for stress incontinence may worsen urgency symptoms, resulting in disappointed patients. The ESTEEM trial was a randomized trial comparing combined behavioral and pelvic floor muscle therapy with midurethral sling to sling alone for the treatment of mixed incontinence. And 85% of all women were better or very much better, and both groups reported reduced urgency symptoms and low rates of additional treatments. These findings suggest several intervention strategies for mixed incontinence. A guideline strategy would recommend non-surgical interventions first to reduce unnecessary surgery. An ESTEEM strategy would suggest initial surgical treatment. A risk factor strategy could also be used, but it is difficult to combine risk factors with just a list of factors. So we could directly benefit more women if these were combined into a single model with the goal of clinical prediction. The primary aim of the current study was to develop and internally validate models to accurately predict a woman's risk of treatment failure 1 year after midurethral sling for mixed incontinence. Since urodynamic information is also costly and requires resources, a secondary aim evaluated the fraction of new prognostic information provided by the urodynamic variables in the presence of clinical information already being considered. Finally, decision curves were used to determine whether the models would provide clinical benefit for women. ESTEEM trial data were used for the study. Women who had moderate or severe mixed incontinence symptoms for at least 3 months and at least 1 stress and 1 urgency incontinent episode on a bladder diary were eligible. Pre-treatment data were used for modeling of 4 outcomes, assessed at 1 year after surgery. Composite treatment failure, defined as not meeting the MID on the UDI total score, or less than 70% improvement in mean daily incontinent episodes on a bladder diary, or undergoing additional treatment for lower urinary tract symptoms. Additional outcomes were the raw UDI total score, total number of incontinent episodes as reported on the bladder diary, and additional treatment for lower urinary tract symptoms. Logistic and linear regression were used. A lasso model and a pre-specified model were first compared. Ultimately, variables were used from the pre-specified model consisting of 6 predictors identified using backward selection: randomized treatment, UDI irritative score, UDI stress score, and ever used overactive bladder medications, cystometrogram demonstrated overactivity, and volume at first urge to urinate. Each outcome was modeled with and without urodynamic parameters to determine incremental predictive value of the urodynamic information. Model performance was assessed using a bias-corrected concordance index, or C statistic, Brier scores, mean absolute error, root mean square error, and calibration curves. Internal validation was performed using bootstrapping. Incremental prognostic value of urodynamic variables was measured by comparing the ratio of several model fit statistics listed. Additionally, a display of added prognostic value was generated using back-to-back high-resolution histograms. A common question about prediction models is, does using the model benefit women, and if so, how much? Decision curve analysis was designed as one way to answer this. Let's say our threshold for not performing a sling in a woman who has a predicted failure rate of 50%, then the net benefit of using the model can be determined. Additionally, if the model red line is to the right or above the 2 gray lines, more women will benefit from using the model compared to not using the model. Study participant flow is shown in the figure. 379 individuals made up the derivation and internal validation cohort for the models in this study. At 1 year, 30% met criteria for composite treatment failure. Mean UDI total score was 37, median total incontinent episodes was 0, and 15% had additional treatment for lower urinary tract symptoms. Model performance is shown in this table. With urodynamics, the treatment failure model discriminated between individuals with a C statistic of 0.72 versus 0.67 without urodynamics. Similar performance was seen for the additional treatment model. The UDI total score model with and without the urodynamic predictors was accurate within an error of 31 and 32 points respectively. The total incontinent episode model was accurate within one incontinent episode, with lower error in the model with urodynamics. These four figures represent calibration curves, or predicted values on the x-axis and actual values on the y-axis. A perfect model will demonstrate a solid black line on the 45-degree diagonal. All models are generally moderately calibrated in the predicted ranges that are clinically useful for patients, with some over or under prediction at the extremes of risk due to low numbers of individuals at these risk levels. This figure demonstrates the added value of the two urodynamic predictors for the composite treatment failure model on the top image and the additional treatment model on the bottom. For each model, the right histogram widened, demonstrating that important prognostic information was added by the urodynamic predictors to each model. These findings were supported by the different ratio indices for fit for all models. The fraction of new prognostic information that was due to the urodynamic variables in all models was substantial and ranged from 19 to 41%, with the urodynamic variables adding most value in the treatment failure model and total incontinent episodes model. The decision curves for models predicting treatment failure and additional treatment are demonstrated here. Notice both red curves are to the right of the light gray lines. For example, the left figure illustrates that if a surgeon decides not to perform a sling in a patient with a risk of failure of 40%, using the model would be equivalent to approximately 0.25, or 25 patients per 100 correctly receiving non-surgical management who failed surgical treatment. In conclusion, these models provide individualized estimates of treatment failure for women undergoing midurethral sling surgery for mixed incontinence. Urodynamic factors add substantial fraction of new prognostic information to patient characteristics and UDI scores in predicting response. An online calculator is being developed for clinical use. Thank you.